Melissa Dellens, LMFT. Melissa, welcome.
Thank you so much. So good to see everybody. Several familiar faces and screens in here. I'm excited. Um,
We can see your screen.
Everybody sees my slides. Excellent. I'm going to move things around so I can see just a little bit more of you, and I want to be able to see my chat screen. All right. Uh, so this is a topic that I'm really passionate about. I have been working in disability inclusion since 2009. I started working as a role as a family support coordinator, and for 15 years, I worked in family homes, helping to include people with autism, learning disabilities, cerebral palsy, genetic disorders, epilepsy, and there's an NOS disorder of anybody who receives services from the regional centers in California came through our agency. And so I've worked with over 100 families and family homes, and working to more deeply include families together and include the person that we were supporting in their communities and the places they work. That put me front row seat to a lot of mental health considerations that were being overlooked and just being trapped into the, at that time, intellectual developmental disability diagnosis, the neurodivergent experience. And that brought me into mental health. And so I have been licensed for some years now. I'm a clinical supervisor, and I work at Outcouch Psychoanalytic Psychotherapy. Some things about me. I love my pets. That is my cat Pinecone and my dog Oliver. I identify as a gender fluid, bisexual femme. I'm neurodivergent. I'm Autistic, which means I'm not autistic. I'm ambiamorous and white and Christian. I am currently in Palm Springs, living uninvited on the ancestral land of the Coahuila Territory and the Agua Caliente Band of Indians. I like being outside as much as my body, the desert heat will allow me to be, and knitting and reading and spending time with Pinecone and Oliver. So you all saw the presentation. I just wanted to drop this in today about the things that we'll be talking about. I wanted to highlight that clinicians have a lot to hold in mind when addressing anxieties relating to expressing authenticity. There can be conflicts and safety considerations, and the client's kind of own experience with their relationship and their environments. There's going to be a lot of content in these slides, and so I'm hoping that this serves as a resource for you too, beyond the hour that I'll be sharing. By the end of this presentation, you should be able to discuss 2 ways to address stress that may lead to a client engaging in masking, and identify 2 ways to support a client to unmask more safely in the context of trusting relationship. I do have a vignette that I'll be using across the presentation to illuminate some of these ideas as we go along. I do want to say that the lessons I've learned from autistic voices, particularly, I have rich neurodivergent community with the ways that my brain and mind works differently. I don't have an autistic experience, and I hold and value everything that I've gotten to learn over the 17 years that I've done this work. It's woven into my presentation. Anytime I've fumbled or making mistakes, appreciation for the opportunity to learn has been extended. I've been able to repair relationships over time, and I'm honored to be part of the collective healing and liberation in the disability community and the larger neurodivergent communities that I'm a part of as well. A note on my references, and I do have my reference section at the end of this slide deck. Autistic people are less likely to enter college than other disabled people, and concerns like interpersonal confidence, scope of interest, and support for executive functioning are limited within the structures and institutions of the way that our universities are built right now. And so my references come from academic and peer-reviewed literature, but they also come from online writings and conversations within the autistic community, both in my own personal history and explorations online, and with the autistic people that I work with in my clinical practice. So we're going to go through a vignette. We're going to talk about social masking, what the mask is, what it looks like, how it builds. We're going to have a sense of structure for it. And then we're going to go through some interventions and some ideas to work with these as well. Feel free to pop questions in as we go. I can send the questions at the end, but if there's something specific that I'm talking about, I'm happy to tend to a question in a moment if it's specific to what we're thinking about together. Okay. So this is an amalgamated client, fictional. She is not a real person, but she carries experiences and traits and stressors that are represented by a lot of the work that I've done. So Juliana is a cisgender, second-generation Mexican-American. She dropped out of her sophomore year of college to get help with panic attacks that were exhausting and took her days to recover from. Her parents took her to a psychiatrist for medication, and then Juliana was referred for evaluation and received an autism diagnosis. Previously high-performing and self-motivated, she is apathetic and unwilling to participate in any effortful activity. Like anytime there is some sort of effort or push or demand, she can't. And she will say, I just can't, I don't know. And there's a frustration with that too, that like she feels like she should be able to. She recently came out to her parents as sapphic queer and is spending most of her time at her girlfriend's house. Her girlfriend recommended therapy out of concern for her apathy and withdrawal from her family. You assess your suicidal ideation in your first session and shares she wouldn't let anyone down like that, but it is hard to keep going. So just drop some thoughts in real quick. Define sapphic queer. So a lot of the younger folks are sapphic comes from the idea of Sappos, from the island of Sappos in Greek, and in earlier times it was an island that was full of women loving women, lesbian experiences, and so it's a lot of young people coming back and reclaiming the word sapphic. And queer is anything that rejects anything of heteronormativity, of patriarchy, of anything that is kind of the traditional mother, father, child family system, that is the ways that our system is really built upon. So queerness is really looking at different ways of being. And a lot of these languages come from online. They come from one of these collective conversations about how to get to like the right word that describes my experience. So sapphic queer is the feminine lesbian experience is often, I am hearing it a lot more in our kind of 16 to 24-year-old range of gay women. Are there anything that you want to think about, Julianne? Yeah, safety concerns maybe explore not just suicide risk, but other less lethal forms of self-harm. Good. Sappho was also an incredible poet. Yes. Love that. Anything else that you want to know about Julianne? Juliana, the slide back up on. Just take a minute here. Shelly, is your mic open? Is she medicated? She is not right now. The psychiatrist had made some recommendations. She and her family are hesitant to starting medication. All right. So Pearson and Rose, how is she supported in her Mexican-American culture? That's a really good question. Oh, I'm going to go back. I'm starting to see some typing happening. She's not particularly much. When we get to getting to know her a little bit more, she is very high performing. She has a perfectionist quality to her. She is really pretty assimilated with assimilated parents, and so it's not something that she's very much in touch with at all at this point. Does she feel safe and that she's safe in a city with ICE so rampant? As she's coming out and exploring all sorts of things, she has so much lack of safety at all because she's having this identity diffusion. Her parents are very reassuring and are not particularly concerned. They're like, we're here legally, we have our papers, they're very like pragmatic about, just keep doing the right thing and stay on the right side of the law and you're not going to have any problem. Her parents are not particularly concerned about, they're concerned in a political way, but not in a kind of personal safety way. And she is quite concerned at this point. Does her family need resources? No, her family is quite resourced, quite wealthy. She is, I think that there is a lot in their wealth that has covered up some of their other marginalized identities as well. Why did she take so long for her diagnosis? This is what we're going to be talking about today, her mask. She has a really, really potent mask that we're going to get into. And so she has a lot of bubbling right under the surface that she didn't let people see for a really, really long time and struggled and suffered by herself. What changed when she was so high achieving? Just wait, we'll get to that answer too. What behavioral observation or self-report led to the questions of possible autism? We'll get there too. I noticed she's 18 and a sophomore in college. Did she skip grades or is she young for her age? We'll get there too. She did. She skipped grades. All right. Really good questions. I'm glad that you're like on the track where we're headed together. So Pearson and Rose are two researchers out of Australia. Dr. Rose is, I'm suddenly spacing on Dr. Rose's name, is an autistic person and does a lot of research on autistic masking. And this resource is in my references. This paper changed my practice. It changed the way that I am looking at autism. It is the way that it changed the way that I'm looking at masking. And so this is the first real model in a published form that we have. I'm looking at autistic and neurodivergent masking and a way to see kind of the etiology of it, how it takes shape and where it comes from. So Amy Pearson and Pearson Rose, thank you so much. So essentially what we see is we see a stressor. We see something happen that comes way out of someone's comfort zone, and they adopt a masked response. They, in some, clinical forms, we can have a defense. We can have a kind of coping, and it might not be the best coping skill, but there's something that happens that, oh, no one's going to know that I'm stressed about this. And that creates its own stress over time, but there's a sustained effort. There's a sustained, nobody can know. I can't let anybody know. I have to keep going. That there's fear for asking for help, and there's a concern about sense of safety. That mask can also create disconnection because when we're cutting off one part of ourselves, we're cutting off a lot of parts of ourselves, and we can cut off relationship and create more internal stress. And then we lose capacity and ability to identify. So when a lot of folks come to us in an autistic burnout or in a place where they're re-exploring diagnosis, there's a lot of inability to identify what's going on with oneself. There's a lot of depression. A lot of autistic masking has been named as depression without really getting into what an autistic experience is being kind of withheld in that mask. And my impression is that this has gotten worse since 2013. There are a lot of good things about the Asperger's diagnosis being removed from the DSM, but it took a top end off of autism that really makes it hard to kind of know how many people before 2013 were being overlooked, and then also how many people identify with some of the higher higher acuity folks that have less support needs, that are starting to see themselves as autistic, kind of understand autism, maybe not have resources, or kind of some professionals saying, you don't need a diagnosis, you don't need a psych assessment. And so that there's a lot that can be put off until someone reaches a melting point like Julianne did. So that meltdown or shutdown can really be perceived clinically in a lot of different ways. So let's talk about unmasking, and we'll come back to that with to this model with Juliana over a hour too. So first, I want to talk a bit about neurodiversity, and we've all been in the GAMPA Wednesdays together. I know that there's a lot of people familiar with neurodiversity here. I know there's a lot of folks that are working with neurodiversity. I want to just do a quick review, but this is a paradigm shift from the medical model of disability and looks at the social model of identity, and looks at the ways that people are uniquely built and what parts of themselves can they claim as theirs without it being seen as a deficit. It's an acceptance that everyone has different ways of thinking, feeling, and relating their experience. It's a move from managing symptoms and behavior to increasing support needs and quality of life. It's a change in focus from the caregiver stressors to understanding lived experiences and really talking to the person who is autistic or neurodivergent, and talking about what they're needing to live a fuller life versus reducing their caregiver's stress. It's also a social justice movement that works to reduce exclusion, discrimination, and marginalization around people who carry intellectual and developmental disability labels. It's largely represented by adults with significant to, this is minor to moderate support needs. Very different. I got that. So we have folks that are working. We have folks that have capacity to communicate. We have folks that have capacity to live on their own. There's a lot of keyboard space, and there's a lot of limitation that are really leading the neurodiversity movement. It was just a special on PBS that was talking about this that I watched recently, but there's some conflicts in the community. People with very significant support needs are really kind of challenged on the edge of neurodiversity as a movement. So there's room for growth and being able to think about people who aren't speaking, people who aren't using the restroom on their own, aren't able to feed themselves, and how do they fully get included in this neurodiverse idea, like people who are struggling with social and rigid behavioral challenges, but able to get along okay in the world until they're not. And so, a lot of those folks were the folks that I was working with in my agency work, and I'm now working with some folks that are falling apart and need some really significant support needs when they come to therapy, but with that support are also able to achieve a lot more of what they want in their world too. So this is just a category of people who identify in neurodivergent community, and is interesting in the last presentation about personality disorders. Do we diagnose? Do we not diagnose? From a neurodivergent-affirming perspective, that diagnosis helps people kind of understand the way that their brain works, and there is a lot less stigma about carrying a borderline personality disorder, a narcissistic personality disorder, and that there's something of being able to say, this is a way in which I struggle, and I want to figure out how to get more support for this. And so there's a whole lot of different ways to think about that from the neurodivergent experience. There is a reclamation of diagnostic language that really gives a kind of shape of the ways people struggle and the way people are really begging for more support, not just kind of for themselves, but on a systemic community level as well. So academic studies of masking is grounded in research around concealment, disclosure, and passing. So the academic work that has been done around masking has been rooted in coming out experiences and closeted experiences in LGBT people, and how people find safety in authentically expressing themselves, what they feel like they have to keep from others, and when they feel like they can authentically be themselves. So this the ways in which people are behaviorally concealing and disclosing or trying to pass as neurotypical, normal, kind of not struggling with any social things, and can really feel like everybody else has the social thing figured out and I don't, and I'm just kind of going along. So working in the intersections of neurodivergence and LGBT identities, it really, this masking stuff gets a very constellation experience in thinking about helping people come into more authenticity. Evidence shows that masking happens more often in girls and women. There are more social rules for girls and women in a lot of ways than there are for men and boys. I think that's changing right now in the manosphere, and there is a lot of masculine expectations that are being more pulled out, but also that there's different cultural contexts that girls and women are more likely to rely on than boys and men are. And there's ways in which trappings of femininity can help people feel more normal. And so a lot of misdiagnosis happens in women and girls, and particularly, high feminine and high performing women, because there is this kind of there's this structure in which a proper young lady can live in that can get really comfortable for someone to feel like they're being accepted. This also creates discrepancies in self-reported symptoms. So people will talk about the ways in which they're experiencing something that they're not presenting to you. When I get stressed, I have this thing where I just go like this all the time, but nobody has ever seen them go like this all the time, because they're doing that on their own in their own space. And and that's just one example. There are all sorts of ways in which, I'm not an assessor, but there's ways in which assessors are kind of rewriting evaluations and thinking about how to get to some of the masked symptoms of autism that girls and women have gotten really good at, capturing and hiding in their social expression. And so Pearson and Rose say autistic women and girls just don't just experience different symptoms, they experience different prejudices as well. And those prejudices to stay away from that, can also get trapped in the mask. So we can think about masking that happens in 5 different domains: social interactions, sensory experiences, cognition, movement, and behavior. And this can happen consciously, it can happen unconsciously. And we know that anytime we do something day over day, week over week, year after year, we can do it without thinking, and it moves into an unconscious place. And there can be something that we don't even realize that we're doing anymore until we slow it down and have an opportunity for someone else to notice and be curious about it with us. So some social interactions, and these are just a brief kind of idea to give you the shape of what the ways that people can mask. Forced eye contact or smiling, and we all smile when we don't want to sometimes. We are all in uncomfortable situations where we are just smiling and nodding along because that's the best we can do right now. These things are things that someone starts having trouble shifting out of, that there stops being other ways of expressing oneself, and that there's a stuckness with that. Scripted conversations, suppressing unwanted parts of personality, learning that there are ways of being that are unacceptable and just tucking those away and not engaging with them when you're with others. Extra efforts to fit in, and attempts to people please, like really wanting to just be accepted, wanting people to know that we're doing a good job and we're trying our best. And so that people pleasing quality can be really, really strong in social masking. So in thinking about this, we're going to pop back to Juliana. She shares in her first couple sessions that her parents have always been delighted by how bright and curious and talkative she was as a child. She did start getting in more trouble in elementary school for not sitting still and talking over the teachers. By middle school, she was playing competitive water polo. She was taking advanced classes, and she did skip 8th grade. Good catch in the chat earlier. She excelled in math and sciences and had strong relationships with her teachers. She didn't have very many close friends, but she was engaged in family and team sports. She got a scholarship to study software engineering at a local prestigious university. So up until she moves to college, she has had a pretty rigorous and successful childhood. I want to look at sensory experiences. The way we can find sensory experiences in the mask is tolerating painful experiences, hiding painful sensory experiences, pushing past one's comfort zone, perfectionism, disconnecting for an ability to describe what's going on for oneself. It is 90 degrees today in Palm Springs. I have a fan. I can feel the air coming down on me right now. And my window is right here. I can feel just a little bit of sunlight behind the blinds. And so even being able to describe the way the weather is impacting my body can become difficult for people who suppress sensory experience. Lost cues for hunger, thirst, sleep, or sex, just a kind of lack of knowing kind of the basic needs. Self-injury and self-harm, and that can be for the purpose of being able to feel something in the shutdown, or just the lack of contact and sense of self with body that a lot of us have experienced with self-injury and self-harm, and all of the reasons in which someone kind of disembodies themselves to feel something. Depersonalization, derealization, and dissociation, in the extreme forms of a sensory shutdown and a neurodivergent experience. So Juliana didn't make her college water polo team. She was really frustrated with the first failure, or what she perceived as her first failure in life. She focused more intensely on her studies, where she was good at, and spent most of her free time in her room playing video games. She was still excelling academically in her first semester, but was avoiding spending time outside and reported getting moody when the weather changed. Her parents reminded her that the pool had always helped her mood. Couldn't she just go for a swim or a gentle float? Like, she didn't have to swim flats, swim laps, or do drills, or just like be big in the pool. And Juliana said she'd given up on sports. She didn't want to go in the pool. So then what's going on the inside? Some things that can happen with a mask is intrusive thoughts about others' intentions, making assumptions about what's going on with someone else, seeing interactions like a game of chess. Okay, if you do that, I'm going to do this. And so like, we're just going to figure out how to move around each other, but that there is always some outcome of win or loss in every social interaction. Self-monitoring and self-critique, automatic assumptions of being in the wrong, rumination over past events or increased worry about future events, and intrusive or obsessive thoughts. So along with Juliana's first session and her psychological eval, the assessor describes low frustration tolerance, repetitive movement under stress, challenges with the assessments that test for cognitive flexibility, and reported sensory sensitivities that she says she didn't want to complain about, but this is the first time she's ever told anybody that there's sensory and environmental things that bother her. I wanted to know when Juliana got a sense of these, like, did something change or has it been hidden all along? When did she start noticing these experiences? She gets really tense and frustrated and she just shrugs. Get more curious, and she starts getting deeply self-critical, and she just starts kind of beating up on herself that she can't do anything right. She is getting everything wrong. And I just asked if it had anything to do with losing water polo, and she kind of nodded a little bit, but no words around not playing water polo anymore. So movement and restriction of movement happens so many ways in autistic folks. If you've ever been around an autistic person with really high support needs, they're constant motion and constant kind of physical body regulation. And so if there is any degree of that neurobiologically in any way in which someone has an autistic experience, restricting that can just be so stressful. It's a really intentional control of body and motion and space where the acceptance is unknown. A lot of times people can end up mirroring and mimicking other people's postures and gestures. And here's the tricky thing: young women coming into adulthood are doing that all the time too, particularly if they're concerned with their manners and their presentation and their like ways of being perceived as a young woman. That there's that mirroring and mimicking older women and role models, those kinds of things are happening too. So that can be kind of tricky when we're looking at this transition age period as well. It can be flat or neutral affect. A lot of times there's emotional incongruence. What's happening on my face or my body can be different than what I'm saying. And if that's pointed out, that can be really uncomfortable and dysregulating. And like, I don't really know, like, oh, you don't look happy right now, or what's going on, or, you know, kind of an inability to describe can create that flat affect. There's, you know, kind of diagnostically autism carries a flat affect. There's a lot of things where we can see folks who did get a diagnosis early on in life, and you can look at pictures earlier on and there was more expression in their face, and over time there is flatter affect. And we can kind of connect flat affect with not autistic presentation, but it can also be developed over time with a mask too, because that emotional incongruence in relationship can be so stressful that it's like, I'm just not going to show you anything. And then that way, neither of us have to be confused about it. And then stimming, we have so many different examples of stimming that, you know, some of you may have already engaging in yourself and sitting in a 4-hour presentation as well, but it's just the ways that our bodies move in with different degrees and intensity over time. So back to Juliana, we can talk about her sensory experiences. She does open up and she shares it's not just about water polo, but spending time with water polo players. She describes the difference in big, assertive physical energy. And she compares that to the physical energy of her cohort of computer programs. She says they're more sensitive. They don't like touch and they think I'm too rambunctious. She had worked to mask a lot of her autistic symptoms in the water polo environment, and they start coming out in the very different kind of social space of software engineers. And she starts getting really frustrated with fitting in. And as she's talking about this, she has this gesture and she just starts going like this with her hands. And she'll just like in her lap, she's just kind of patting her hands, and it's kind of regulating her frustration about moving social groups and not being able to fit in as well. So things we can think about with behavioral masking, performing uncomfortable behavior, mirroring and mimicking other people's behaviors, forced compliance without actually understanding. If someone just tells me what to do, I'm going to do it without asking about it, just to cut off any sort of conflict around it. Maybe ignoring safety cues, either internal or external. And this can move itself into higher, riskier behaviors as well, sexual behaviors, addiction and compulsive behaviors, eating disorders. And all of that, it can be rooted in not asking for help, and then even moving into self-injury and suicidality in this really high stakes place of needing to be normal. So we had this panic attack in college, and we're coming back to this in therapy, and she shares she didn't know what was wrong with her. Everything kept getting more difficult. She had less patience, and she felt like she was getting dumber. Whenever something difficult would happen, she would open the email announcing the water polo team. She said it was dumb, but she kept looking over the email thinking she missed her name, and when she even panicked when she didn't see herself on the list. In tryouts the year before, one of the girls on the team had reached out to Juliana, interested in being friends. Juliana has started spending more and more time with her, and shared she could pretty much only deal with sex, snuggles, and video games with her new friend. And anytime there was anything beyond that, she would move to panic. And at that time, she said she was also afraid her parents wouldn't tolerate her relationship. And so she avoided telling them as long as she could too. So that, early sexual exploration also kept her from reaching out to her parents, who had been her primary support system as well. All right. So that is for the sake of an hour, a really kind of quick review of the ways the mask can build and a little bit of a shape of it. Is there any questions before I move on to some ideas about how we deal with it? Okay. I'm going to keep an eye on the chat. I am going to come back to this model again and kind of think about this with everything that we took in about Juliana's experience, about what a mask can look like, and how we can think about it specifically for her. So her stressor became feelings of rejection and failure for not making the water polo team. She denied interest in it. She generalized messages about failure. She changed social groups, and she starts masking to fit in. That increased effort in academics created an imbalance in her school and social life, that really the performance in her classes became the make or break in her sense of self. That led to increased self-criticism. The not making the water polo team left less time in the pool for physical and emotional self-care. And because she just literally a fish out of water in some ways, and we use this fish out of water metaphor, that believing that her ways of being were wrong in being in this entirely different academic environment. It adds to isolation, increased panic, and numbing activities, the sex and the video games. So this burnout looks like, basically staying with her girlfriend the whole time, avoiding responsibilities with her family, depressed symptoms, and that kind of suicidal ideation. She isn't demonstrating any self-injury or self-harm beyond this presentation. There's no cutting or anything like that, cutting or burning or anything, but she is having a really, really hard time. So affirmative therapy, one of the primary tenets of this model is exploring beliefs that are rooted in medical models versus social identity models. And even when we think about LGBT affirmative therapy, homosexuality was diagnostic until the mid-70s, right? I think. And so like there was an experience in the LGBT communities of affirming differences in sexuality and gender that clinicians did and still have to do, removed in 1973. Thank you. That had to, kind of reassure clients that this is a safe place to be exactly who you are, and really help kind of undo the medicalized harm. And there's a lot in autistic and neurodivergent and disability communities that have been medicalized in different ways. And so moving into a social identity model, following that same kind of path really helps people move into a more authentic sense of being. Addressing minority stressors, addressing missing support needs and providing affirmative referrals, excavating internalized shame, encouraging community connections, and self-care, coping, and resilience. So these are the things that we're doing from an affirming lens to help someone who is dealing with some internalized shame about a sense of part of who they are. So a couple of things, I had this slide in a different ways, but I just want to think about the clinical context that the medical model is really deficit focused, and we're focused on symptoms that we're attending to, and we're looking to reduce those symptoms. We're looking to get to like a normal level of functioning, however that normal is defined in a medical level. Depending on an autistic experience, it can be really caregiver centered in reducing stress of the person who is primarily responsible for someone. And there's a lot of segregated school and work experiences in disability. So the social identity model looks at focusing on enhancing quality of life, considering differences with a cultural humility, explores and considers support needs, is person-centered, and looking at inclusive support to help people engage more in work and school and keep people in work and school and in their families, rather than moving towards that segregation struggle. So these are potential minority stressors, and this is broad, and so I didn't write this specifically for Juliana, but these are things that we can think about in someone who comes to us in kind of an identity diffuse place and not knowing really who they are. And, as she is moving into more of a social identity experience, that someone asked about how she supported in her second generation Mexican American experience. She hadn't been up to that point, and that could become more important to her. And we might see more minority stress that we're managing there as well. That may also be some constellation of her mask too. So we're looking at her sexuality, we're looking at her ethnicity and racialized experiences, and on all of these things that can get wrapped up in this perfectionistic mask that she's developed to hide not only her autism, but some of these other minority experiences too. I really like the ecological model. I learned about this in my community work before therapy, and this kind of radiating concentric circles is a way that I've helped families for a really long time think about how to increase support needs. And so looking at the individual themselves, being able to assess how their daily living skills are, how their organized communication, there's like all of these kind of mental status exam kind of things. We can look at like how well a person is doing just on their own, how strong their support system is, how many people are in their life, and from how many different areas of their life. And then membership and belonging. When I was doing my agency work, our executive director used to say, where are places that if you didn't show up, you would be missed? I'm not actively involved in GAMFA as much as I did when I was in LA, but if I didn't log on for my presentation, Jim and Marianne would be wondering where I am. And that's a sense of membership. And so membership is really like where do people go where if they don't show up, someone's going to be worried about them. And then community access. Can they get around their community? Do they have work, ability to financial stability, stable housing, support services, medical care, political advocacy? And those three become so much bigger the more someone moves into a neurodivergent identity and starts holding on to getting more of what they need to live more fully and more supportedly in their life. So the other thing to think about is you should not be your only client's only person. I had this experience where I was working with someone, and I think there's some people in the room that have heard this story before, but she emailed and was just going to quit therapy and was just done. And I encouraged her into a second session. And we uncovered that I was the only person she was speaking to in the week. And she represented a strong social support. She had friends, she had, activities, she had things she was doing, but they were all digital, and I had missed that. And the way that she presented it felt so robust and embodied. But what we got to was that, like, this was the only time that she was speaking, and it was 45 minutes, and it was really, really stressful for her. We were able to make some accommodations and move that, but that was also the beginning of the work of her mask. And I realized that I was the only kind of person that was like in this with her. And so, if those moments come along, being able to think about other people that can be a part of someone's support system and help make life a little bit easier. Lots of ways we can think about shame. There's so many opportunities to be shamed about who we are and what we're doing in this world. And one of the things that affirmative therapy does is normalizing anxiety, depression, and panic as reactions to minority stress, and tending to minority stress first. And some of that can be coping skills and embodied experiences and all of that. But like, you're doing the best you can, and this is your body's way of saying it's too much. From a psychoanalytic place, I'm exploring and validating early and ongoing minority stressors, particularly what it means to have a misdiagnosis, what it means to have so many significant sensory and behavioral needs overlooked for such a long period of time. Being able to encourage authentic self-expression. This thing for a while became just the beginning for Juliana, that she that it was ways in which she needed to move her body big a lot of the times, and losing water polo just drew attention to how much that stimulation. Martha, can you please identify minority stress? So there is a minority stress model, and I may have it in my references, and if not, I can add it along with Jim and Marianne. And basically it looks at the way that marginalized people, either if it's through race, gender, sexuality, ability, documentation and citizenship status, experience different relations. So discrimination, victimization, experiences of masking, experiences of having to hide oneself, and then all the way up till legal ramifications. Things like Hispanic and Latin people's lives being so impacted by ICE raids right now is a minority stressor. So anything that is directly impacts someone because of some sort of minority experience that they carry. It's a good question. And then we're, continuing to work with the rigidities of autism and disability and things that the mask have developed to be able to to loosen things up and help someone feel a little bit more safer in their body and in their relationships and in their family. Therapy can also be a place to understand masking dynamics, understand why something took shape and why it's being used, and have some flexibility. You know, people who come out of the closet aren't always out of the closet now. There's a decision about when someone knows something about someone's gender or someone's sexuality, and being able to have a flexibility based on safety, based on interest in disclosure, that this decision becomes mine to express when I want to and how I want to. Developing the compassion for the mask and knowing that it can be exhausting. There can be high masking experiences that then, if I know that I'm going to do this, I'm going to take a day off tomorrow. Like, you know, to give myself a little bit of a downtime for the way that I kind of put myself up. You'll hear other clinicians say that like the work is to make the mask need to go away. I don't think it is. I think that it's about flexibility in masking and a really intentional, like feeling more intentional in choice in the way that someone presents. I think that there's a lot more systemic and individual and like institutional problems that need to go away in order for a mask to go away. Like the mask still has to exist. And exploring safety considerations, like I just said, about that existence. For our Juliana, we're looking for barriers of getting back in the pool and some ways of coping before the mask as well. And working to find that authenticity. Some resilience work would be around exploring the meaning of an autism diagnosis, consideration and validation of her authenticity, exploring all the ways that other people miss of autistic expression too. Awareness of how she was able to work so hard, like, you know, in that performance being able to be a choice, that she has a rigor, she has a really high expectations of herself, and that got exhausted, and that kind of like anything that's effort, I don't want anymore. Kind of working with that to modulate that and be able to kind of find the right balance of working at a level that works for her. She also got a lot out of acknowledgement and praise from others, and that was really where her performance came from, is how much she was doing, winning a water polo game, winning a meet, you know, like winning became so important that this mask just continued to find its way. And then figuring out new support structures and systems. And that comes from the Brockenbrenner's model to think about that. It's a lot of suppression and repression that happens in masking. A lot of comfortable space for spontaneity of movement, being curious about stimming behaviors, allowing for new aspects, exploring dreams and desires, what someone really wants for themselves, finding new ways to communicate, developing specific support needs, and allowing this to be an iterative process, that the more someone comes into themselves, the more someone understands the ways that their mind and their brain work differently, the more they're going to be able to identify and put words to what they need. And as environments change, as life, you know, kind of lifespan needs change, support needs can change too. And so kind of an ongoing experience of what it can look like to help someone notice when the mask is coming, and what that means and what they can do to learn about it in new ways. So that's what I have for you. I am so grateful to be able to present. I know we've got a few minutes. If there's any other questions, I can tend to those, any thoughts that anybody has. And I'm also leaving everybody with a coupon code for the CEs that we have in our library at Outcouch Psychoanalytic Psychotherapy as well, from the Indoctrinated. So I'm grateful to be here.
Thank you so
Questions?
much, Melissa. This is
Thank
so
you, Melissa.
thorough.
I see Martha has a hand up.
Yeah, hi. Thank you. That
Hi,
was
Martha.
a lovely presentation. I have a question. when you are working with someone, I had a couple and I began to think that the man who was part of the couple was on the spectrum, but he hadn't mentioned it at all. And I was really pondering about how do I introduce this notion. And because I thought it was, some of what she was reacting to were clearly traits that she was misinterpreting that seemed to me to be clearly on the spectrum. I waited at one point, he said, I think I'm on the spectrum. And I just, I said, oh, well, what makes you think that? So, but
Mhm.
I'm wondering, how do you introduce that if you have a feeling that that might be what's going on, but the person has not yet come to that or been diagnosed with that?
Yeah, I have I think that a lot of it comes from experience that I have so many different kind of places in which autism has been um there's so many different presentations of autism, right? And so uh it can be really about exploring the things that we're noticing. And it's so interesting because in 2009, everybody around my agency was wearing these shirts that said label jars, not people. It was a very different social kind of model of the ways that we were like not talking about autism, but we were talking about behaviors and we were talking about ways in which people are struggling to fit in and struggling to reach each other. And so I think that there is something to just being able to continue to observe what you're seeing.
Mhm.
And if that observation comes to a point, it everybody might come to the same point at the same time. But I because I'm not an assessor, because people will come to me based on my marketing looking for an autism diagnosis and I'm not an assessor, I'll meet with someone and kind of say what I think that they might get out of an assessment. And if that's a path to go. But um a lot of times there is this just kind of as someone gets to see themselves better, there's a kind of coming to that I've experienced too.
Yeah.
Um,
Okay.
I just went to a CE by Grazel Garcia, and she talked about neurodivergence in couples therapy and what's an attachment wound and what's a neurodivergent difference. And it was a fascinating conversation about being able to make distinctions in attachment wound and neurodivergent difference.
Thank you.
Oh, seeing all the great jobs. Thank you, everybody. You're so kind. Um, thank you. Thank you.
Daria, is that a question?
I did have a quick question. Sorry.
Hi,
Uh,
Daria.
Hi. I like the presentation. Are there any quick tips with someone who doesn't have, I know you mentioned one of the things is not having an urge to eat. And I had a client who had that. They knew that they felt better when they did eat, but just didn't have that urge and was also, well, anyway, I know we don't have a time. So if there's any quick
Yeah.
tips for
Um,
that.
Kimberly's in the room and I've learned about the trauma resilience model from and Kimberly and I have had a lot more conversations about that. But having some sort of somatic experience to work with interoception, with be able to work with body feeling. And if food stuff is really an issue, getting a registered dietitian who is also an eating disorder specialist on board can be really helpful too. And a lot of autistic folks work with eating disorder specialists because there's so much food sensitivity. There's so
Mm.
much like limited palate, and then also different sensory cues in the body as well that getting I should add that to my slide deck too. Getting RDs on board can be really helpful.
Oh, cool. Thank you.
All right. Oh, wonderful audience. Thank you so much for your activity in the chat and letting me share some of the work that I do.
Thank you very much, Melissa.
You're very welcome.